Good morning, East Coast, West Coast fellows, and surgeons around the world. We really appreciate your participation in December of 2024 for our fellow project with Dr. Judy Chen and Dr. Leena Khaitan. I'm going to go ahead and let Dr. Wilson give us our announcements for the month and put a few links in the chat as she's talking.
All right, good morning, everyone. Welcome to the last month of the year, December, and I hope you all are staying safe with this, with the weather and incoming snowstorms that we're starting to see for the season. So just a few announcements. For one, the ASMBS annual meeting abstract deadline is coming up. So we're accepting abstracts now, and the deadline is January the 8th. So be sure to, if you haven't, use this as an opportunity to fulfill your academic involvement and scholarly requirement for your ASMBS certificate. This is a great opportunity. So submit any abstracts, papers, videos from your fellowship. Submit that as soon as you can. Deadline is January 8th. The next bariatric happy hour is coming up December 19th. And we have a request, and we'll put the link in the chat for you to submit questions. In February, we'll have a fireside chat for our bariatric happy hour. So you can submit your questions, and it can be like an open forum for discussion. So I think we think it'll be a really rich experience and rich time. And again, the annual meeting is June the 15th through the 19th of next year in National Harbor, Maryland, or Washington, D.C. And those are the bulk of the announcements, and I'll let Shaina make an announcement about membership.
So just wanted you guys to be aware, if you have not joined as a trainee, uh, membership is, I believe, free as an ASMBS candidate. If you're already a member, it is time to renew your membership. So please feel free to use that QR code that I have posted. Take a quick screenshot while I make our announcements and pass over the presentation to Dr. Chen. Dr. Chen will be our first speaker today. She's a board certified surgeon who practices bariatric surgery at University of Washington in Seattle. She has got her focused practice designation in bariatric surgery, and she's obesity medicine board certified as well. She's the director of the Adolescent Bariatric Surgery Program, associate medical director of infection control, and an associate professor of surgery. She's also an affiliate faculty member in the Diabetes Institute and Division of Healthcare Simulation. And then she also participates significantly in our the medical student education as associate clerkship director at University of Washington. Our second speaker today is Dr. Leena Khaitan. She is joining us as our expert in all things. Oh, I just lost my notes. Bear with me for 1 second. From Case Western, as a full professor, she's the chair of the Flexible Endoscopy Committee at ASMBS, and she is one of our leading experts in bariatric endoscopy, and we're really excited to have her participate as well. Dr. Chen, I'll give it over to you. Stop sharing my screen so you can go ahead and get started. Thank you for joining us.
All right, thank you so much, Dr. Eckhouse. So just confirming that presentation is up. And so I appreciate the introduction. Really, thank you for the invitation to speak. I'm really excited to return to the Fellows Project. I was able to start as a moderator, so I was joining monthly for a few years, but at the West Coast time. But it's, I think, such a fantastic curriculum, so much knowledge here. Please return to presentations of the past. There's another endoscopy presentation that Dr. Khaitan also gave earlier that goes over things that we don't go over today. So it's a really fantastic curriculum, and thank you again for carrying the hard work, Dr. Wilson, Dr. Eckhouse. So I have no financial disclosures, but as mentioned before, I am a part of the Flexible Endoscopy Committee, which Dr. Khaitan is the chair with ASMBS. I'm also the co-chair for the Metabolic Bariatric Surgery Committee with SAGES. I absolutely encourage everyone here to join committees, but in particular, if you're interested in Flex Endo, we welcome those with interest in training to move forward clinical applications. It's a really exciting part of our bariatric uh, care and treatment model right now. I think there's a lot going on, as well as, research related to endoscopic therapies for patients with obesity. This is the committee where BESAFE, or otherwise Bariatric Endoscopic Skill Acquisition Focus Evaluation, is what it stands for, was first developed. We're currently updating it to really try to reflect all the changes of literature. And so it's a ASMBS and SAGES supported verification process for members performing endoscopy. Objectives today are for me to kind of really just do a brief introduction to indications regarding endoscopy before and after metabolic bariatric surgery. I also want to go over considerations of endoscopic and anatomical findings, especially in those common bariatric procedures you're familiar with, the adjustable gastric band, the sleeve, the roux, the duodenal switch, vertical band gastroplasty. Not only do you need to know how to operate, you should know what it looks like intraluminally, because it's incredibly important regarding understanding maybe what the patient might be presenting with, knowing what normal anatomy is and abnormal anatomy. And lastly, as I mentioned, I will go over just quick overview benefits of the BESAFE verification process. So the endoscope is an integral tool for a bariatric surgeon. The ASMBS in 2021 published a position statement, and this is really important for everyone who does bariatric surgery endoscopy to be familiar with this particular statement, because it helps us to gather the evidence as of at least 2021 about the performance of using upper GI endoscopy before and after surgery. It allows for preoperative planning. There's clear literature showing that findings can alter your decision and consent for what operation to do and talk to the patients about. It provides information about current anatomy, hiatal hernia, the degree of pathology that we see in the foregut, information like H. pylori status. And so to summarize this particular position statement, yes, routine preoperative endoscopy is justifiable before all metabolic and bariatric surgery. We know that symptoms do not correlate to what we can see on endoscopy. Patients often have endoscopic findings without clinical reflux, and so silent reflux can be seen in patients with obesity. And if reflux is clinically present, you do an endoscopy, you find objective findings that are consistent, or you perform pH and even manometry with abnormalities. This position statement does say really consider the Roux-en-Y gastric bypass given the reflexogenic nature of sleeve gastrectomy, if those are the two options you're thinking of. In regards to findings after bariatric surgery, the position statement does say that with Barrett's, there does need to be a little bit more literature. There can be findings, but we don't really know clinically how significant those are, because the progression of Barrett's is long and latent. After bariatric surgery, endoscopy can be considered for those who have symptoms, but there's not recommendations to routine surveillance. Although for a sleeve, it can be reasonable to perform an endoscopy 3 years after a sleeve despite no symptoms, and then considering potentially 5-year intervals. So those are parts of the position statements, and again, to be familiar with that. Moving on, just thinking about endoscopy, it's important to consider having a safe procedure. That goes into what sedation you want to decide for appropriateness for your patient. That can be dependent on many things. In my institution, we have a policy that anyone with a BMI of 40 must have anesthesia. So you have to be aware of what your institution or center has for policies. But of course, you want to understand the ASA status of your patient, think about what their medical conditions are, especially with recent popularity of GLP-1 receptor agonist medications. You, of course, need to take a thorough history, looking at organ dysfunction and how medical sedation meds would be metabolized. Sometimes it takes much more sedation for our patients. So you want to be aware of organ dysfunction, liver dysfunction, kidney dysfunction, of course, obstructive sleep apnea with respiratory risk, cardiopulmonary concerns like pulmonary hypertension can be seen. Physical exam, of course, absolutely understand what your patient's airway, neck exam, using scales like the Mallampati score so that you can evaluate their oral pharynx and palate, uvula. And then really just having the proper equipment, being familiar with the endoscopic equipment. But outside of that, what you might need is to be familiar with rescue maneuvers. You have to make sure that if there's any concern that you maintain airway using things like jaw thrust maneuver, suctioning, bag mask ventilation. You can also place a nasal oral airway in our patients and other things to help, again, rescue and provide a very safe procedure. But this picture, we've come a long way over having endoscopy available in the past 100 years. This is a picture of someone who needs to be inclined downwards to decrease that secretion. This is a rigid scope. We're lucky that we have flexible fiber optics with suctioning, multiple channels. So it's just really great to know that we have wonderful tools now. But I love history and medical illustrations from the past. So I just had to share this one. I do want to just point out that there is a FDA warning in regards to GLP and pulmonary aspiration risks. This is a medication that many of our patients are on, and this has kind of been something that, at least for me in my institution, we have had to update guidelines. And so I wanted to share the American Society of Anesthesiologists guidelines, as well as the American Gastroenterology Association guidelines. And you can see here that there are recommendations to instruct patients to hold weekly GLPs for a week, or they have daily GLPs to hold them the day before, to understand what MPO status your institution might recommend. And basically to really hone down right before endoscopy, what symptoms might they be experiencing? And that will guide you to if you need to do any sort of other imaging or ultrasound. Do you need to delay the case if they do clearly have symptoms of a full stomach, or any modifications? And so, as I mentioned before, you want to ask your patients, are they nauseous? Do they have more symptoms with reflux or gastric fullness and halitosis even? And here's a study from JAMA published this year in 2024 that they looked at patients undergoing sedation anesthesia, and they did ultrasounds on all their patients. Specifically, the residual gastric content was defined as solid or thick liquid on ultrasound. And what they found in this population is that patients with a taking GLP-1 agonist had the defined residual gastric contents in 56% of their population versus 19%. So being on this medication can potentially increase, of course, the food in the stomach, the gastroparesis. Hard time sometimes doing your endoscopy work when there's quite a food load. And of course, you just don't want that to have a risk of aspiration. So those are things to think about. So really, again, when you perform endoscopies, you want to do it consistently. So whenever I have trainees come, residents, my fellows, I try to always have them really do it very strategically, because you may forget to, evaluate part of the anatomy, the Z-line, or not remember to measure it on the endoscopy. So I really try to have them really think about when they are starting the case to have certain landmarks to always hit and make sure that you evaluate thoroughly. And of course, it's easiest to go from proximal to distal. So I always have them try not to insufflate as much, because you can get a better idea of the diaphragmatic impression or hiatal hernia before you reduce it, because we know that hiatal hernias can slide. You can see luminal findings or motility without kind of over insufflating, which I think as beginners, we often over insufflate. So that's something to just continue to refine. To, of course, look at contents and how the scope feels. It really is important, like when we cross certain areas like strictures, you can feel the resistance and you have a lot of information with that. And then, of course, gastric and duodenal findings related to mucosal findings are always important. So let's switch to talking about common metabolic surgeries and what they look like from the inside, and specifically the endoscopic inside, not the intraoperative inside. But it's fundamental knowledge for a surgeon to really understand what the luminal endoscopic views should be. As we all know, there's many different ways to perform some of our operations, from circular anastomosis versus side to side, anticolic versus retrocolic. And so those are all incredibly important to understand variations, but it's also good to have that baseline to what these cases or these operations would look like. So there are definitely patients who still have the adjustable gastric band. And in regards to endoscopy, as I mentioned before, you want to look at the esophagus. There can be because of the restriction, the esophagus can dilate. So you really want to understand, is it tortuous? Is it dilated? Is there poor tone? What's the location of the band in relation to the Z-line? I've had gastroenterologists call a hiatal hernia, but it's really just the gastric pouch. You want to, of course, as I mentioned, think about reflux, esophagitis, Barrett's in the setting of a band. Understand what the lumen looks like. Is there pooling of the saliva above the band? How tight is the band? Can you pass it? When you retroflex, it's essential to rule out erosions or other things. You can also kind of have a sense of the band positioning in the gastric pouch. You can see dilated pouches, and that all, again, goes together with your X-ray, where you can look at the phi angle of the band. And so these are all incredibly important, because again, I have lots of experiences where GI doctors think that this might be a fundoplication, or they think it's a hiatal hernia, or they dilate the band. So we, as the experts in this, want to document adjustable gastric band findings very consistently. Moving on to the sleeve gastrectomy, the lumen of the sleeve is, of course, important in regards to the uniformity, but we can sometimes see a little bit of dilation of the fundus, especially if the sleeve has been present for a long time. You want to look at angulation of the incisura areas of narrowing. You can retroflex sometimes in the proximal portion, but absolutely in the antrum or distal portion of the sleeve to look at how the incisura looks. That's tight. Again, mucosal findings, motility, stasis. It's really important where, again, is there pooling of food or other things and other landmarks in the sleeve gastrectomy. Next is the Roux-en-Y gastric bypass. Similarly, Z-line, hiatal hernia, esophageal findings, strictures. Incredibly important to look at pouch size and just be consistent in how you do it. You can use, again, the markings on the scope. So when you are at the esophageal gastric junction, where's the anastomosis as you exit in centimeters, you can use tools like snares, biopsies, to measure the length of the pouch. You can, of course, with the gastrojejunal anastomosis, also talk about how your scope can pass it if it's a stricture. Use tools that Dr. Khaitan will talk about if you find pathology, but really important to get a good view of the anastomosis. Ulcers are on the jejunal side. You can have secondary findings such as inflammation, or sometimes it's really hard to see it when you first advance. If you're able to retroflex, you can really see ulcers much better. Of course, as I mentioned, and all the other endoscopies, hiatal hernias, other things like retained suture, staples, bleeding, gastric fistulas. I think if you're really suspicious, you have to really interrogate that pouch to sometimes find that fistula. And as you get further down into the jejunum, making sure you understand the roux limb versus that small blind pouch. Most of us make it with an endoside, and so there's always a little bit of the blind pouch that can be called candy cane since it's the holidays, or a shepherd's hook. So there's lots of ways to really understand that if your patients are having problems with food stasis, is it because of the length of the candy cane? Or is there any bile there? Because we should never see bile in the roux limb. And so all of these things are incredibly important. The anticolic versus retrocolic. So when I see some luminal narrowing, my partner does a retrocolic, so I know that that's part of the normal anatomy. Next is the duodenal switch. The sleeve portion of the duodenal switch is usually bigger, and so you can, of course, still comment on dilated portions, strictures, twisting. When you go to the pylorus, what's the length between that and the staple line? Is there any angulation of your anastomosis? Is it a single lumen or a double lumen? As there's two versions of the duodenal switch, and as I has really pointed out, lots of characteristics and pathology of what you can see with these different endoscopic evaluations, and again, of normal anatomy. And then lastly is the vertical band gastroplasty. This can be mistaken for a paraesophageal hernia. I've also had a patient who was thought to have a gastric mass, but it was actually eroding mesh. So it really depends on, if you have operative notes, what type of restriction was used, because there can be Phobie bands or mesh or red rubber catheter, but so important for the tool and understanding for the patient and their anatomy afterwards. And so that part is important for you when you're doing endoscopy, to know what might be a part of what surgery that patient had. The last part of my presentation is really to focus or give a brief introduction to, as I mentioned before, the BESAFE verification certification. Very easy to go to the website to get more instructions, but the steps are here. You need to have 50 endoscopies done prior to taking this, and so we do request the evidence that you perform 50 endoscopies. You create an account, you watch 8 videos or curriculum that go into much more detail. You will take a written exam, which you have to score greater than 70%. And then the hands-on exam portion is only held once or twice a year. And the next one is at the ASMBS annual meeting in 2025, as mentioned, in the DC, Baltimore area. So there's usually only 6 to maybe 12 spots. So you should sign up as quick as possible, because once those are full, we don't add on more. So this is an important part of understanding. And just to reiterate that this really just builds on the endoscopic training that you have already received. This is meant for a verification. You should have a background, of course, in understanding these anatomies and how to address things. And this is not meant to learn new procedures on. You should do that, of course, in the appropriate instructions or formal institutions or recognized authorities. So, but this is an incredible certification. I think it really allows for you to come to your institution to show that you have these verification certifications through ASMBS and SAGES. So I want to thank everybody for your time for the first half of this morning.
Really excited to have Dr. Khaitan here. Thank you so much for joining.
Thank you guys. Really appreciate you having me on today. This project is so important, and all the hard work you do on this is fantastic. Our fellows get so much out of it, and just appreciate all the hard work you do. And then I also want to say that Judy is extremely humble in that she is the lead for our BESAFE now for the last, I want to say, year and a half, 2 years. She's been doing a phenomenal job and really doing an overhaul on that whole BESAFE project, which is really, really needed. And she's her leadership has been phenomenal in this space. So super excited to be on the panel with her. It's a privilege, and also with our moderators as well. So I'm going to share with you a little bit about endoscopic management of complications and where does endoscopy fall in, so it's really important. So Judy went over various a normal anatomy, but we know in bariatric surgery we say abnormal anatomy all the time, right? And I just wanted to follow up on that question you had about repeating your own scopes. I think that, if your scope doesn't have every piece of information that Judy said that we should have for altered anatomy, like proper description of the incisura, retroflexion distal in the stomach, measurements of the inlet and the outlet of the gastric pouch for a gastric bypass. If all of these things aren't specified in the report, then you should do your own endoscopy, because otherwise you're going to get burned. You're going to find something when you go to operate or say you're going to fix something, and then you're going to be like, oh, I wish I would have known about XYZ. And if you had done your own scope, you probably would know that. So bleeding is definitely something that we see a lot of, right? And where can the bleeding happen from? Let me see if I can move these. So, okay. Can you guys see the whole screen now? I think that was covering. So bleeding, the first thing we're going to think about is this an ulcer at the gastrojejunostomy? Common things being common, bleeding at the GJ from an ulceration is going to be the number one in my differential. And so important to be able to scope that pouch, know what's normal. And these ulcers can be very indolent. It can be like they're sitting in a corner somewhere and you can't really see it really well. And I can't tell you how many times I've been told that there was no ulceration, and then I go do a scope and I see an ulcer. So this patient happens to have a little ulceration right there, and then down below you can see something that's bleeding. So if this patient didn't have bariatric surgery, your friendly gastroenterologist would say, okay, let me inject it, let me clip it. But you know what, as a bariatric surgeon who also knows endoscopy, knowing how to clip, how to inject are two very, very important skills to have in your toolbox so that you can manage this on your own, because you know that anatomy better than anybody else, unless you happen to have a partner who is a gastroenterologist who's very facile with bariatric anatomy and they're engaged in your bariatric program. So knowing how to clip, how to inject is really important. So there are a couple different clips out there, and some by Boston, as well as a couple other companies. I like the Boston ones. That's what we have here at our institution. One of the nice things about this clip is that it spins. So if you bring the clip in and it's not sitting in the orientation that you want, you can actually rotate it to get it to the right orientation. And then you want to, as you can see in panel B here, you want to make sure that you get to the right and left of what you're trying to get. And the clips actually open about almost twice the diameter that you see here when they're initially opened. You want to get all the way around it, and then you want to squeeze, and that releases the clip. And sometimes you need to use multiple clips, as you see in panel C. So that's an important skill to have. And if you did the training for BESAFE, for example, you would learn how to do this skill. We also inject for these. So we can, we have little needles that we can place through our endoscope where you can inject some epinephrine. And generally I'll inject it in a couple quadrants around the site, and to help to kind of spasm the vessels that are around, in addition to the mechanical clipping of the vessel as well. So knowing how to use these and communicate with your nurse is really important, you know. And I think, you know, I made this like kind of a very case-based kind of talk. So here is a patient that we actually ended up managing endoscopically. This is from several years ago, but I had a 39-year-old woman who was a week after her sleeve, and she came to the office with shoulder pain. And of course, you know, that's not what you would expect. You expect him just to be walking around, look like a normal, happy, healthy person. So we were a little concerned. So we got an upper GI, and if you see here, you see this tiny little outpouching of contrast outside the lumen, and maybe a stream going out here. So definitely not what we want to see. So we're like, okay, well, this is not good. You know, looks like there's a possible leak here. So what are we going to do about this? Well, you could take her to the operating room and you could try to sew over, but it's going to be very, very inflamed. And it's going to be tough to bring, you know, to sew that together. Your stitches probably aren't going to be held well. And patients don't want another operation. So what can we do endoscopically? Well, here we have a skill. And so what we did is we found the hole, and we put in a stent. I'm sorry, where did the pictures go of us placing the stent? But what we did is we put a stent over this to cover over the hole. And then a month later, we left it in place. The nice thing about a stent is that patients can eat through it, they can drink through it. It's very uncomfortable for patients. It leads to a lot of heartburn, reflux. But if you can just kind of talk the person through it, and she wasn't able to drink enough to sustain her nutrition, so we had her on TPN as well. And then when we went to take out the stent, now we actually still have an opening there. You can see a fistula. She didn't have a white count. She was never excessively tachycardic or anything throughout this whole thing. So we just did a short course of antibiotics, but now we have a very clean opening, as you can see here, to the fistula, and no more inflammation, but still there's a hole. So we don't want to leave her with a hole. And so what we were able to do is then take an over the scope clip and put it through. So I think, okay, now I have in here a little bit more about this. So we have all different kinds of stents. You have covered stents, uncovered stents. They come in different lengths. There's actually one that's super long, twice as long, that's available outside the United States. Not available to us, but has been used in sleeves. But basically, you want to make sure that you choose the right diameter, and you want to get one that's fully covered. Partially covered ones in this space get way too much ingrowth, and so they can become a little bit more difficult to remove later. But you do want to have some hooks at the ends. The nice thing about the partially covered is that they're less likely to migrate because they do get that ingrowth. So that's one of the challenges with stents. You want to balance the migration with the covering of the hole so that it can kind of calm down. And then one of the newest stents that we have on the market are these little Axio stents that are very short, that we've used in my practice either for edge procedures. So if we want to get access to the gastric remnant and to go across there and get into the gastric remnant looking for the source of a bleed, for example, in the remnant stomach. Interestingly, if you use these, my biggest concern with using these for the edge procedure is leaving a persistent gastric fistula. As Judy showed you, a fistula was just generally something we don't want to have. But you can actually remove these, and 80% of them will actually close on their own, interestingly. So it's not as scary as I initially thought, now that we have some information on that. And the other place we've used is a gastrojejunostomy stricture. In fact, one of our patients just got one this week. So this patient had this over this that persistent hole, and what we did is we used an over the scope clip. You can see my scope right here. You can see this hole was right at the top of the sleeve, and we put a little Ovesco clip on it, and we closed it up. We got another study, and now there was no extravasation of contrast. This is another patient where we were able to manage endoscopically. This is a woman who came in with abdominal pain, nausea, vomiting, and showed some free air outside of her pouch. And when she got an upper GI, and we see this little extravasation of contrast here. What else was unique about this patient is that she had had multiple operations, including a total abdominal wall reconstruction. And so she had an abdomen that we definitely didn't want to go into. She was sick, but not peritonitic. And when we scoped her, this is what we found. We found this ulceration. And so our options at this point, knowing she's got extravasation of contrast, we see a hole, we can either go in surgically and try to find the hole and try to sew it or put a drain next to it or something. But for this particular patient, we didn't want to go in the abdomen that way. And we could see that the contrast, the leakage, was fairly contained up in this area, probably because she had so many adhesions from her prior surgery. She was post-bypass. On further questioning, it turns out that she was taking a bunch of NSAIDs, and that's probably where the ulceration came from. And again, we used one of those over-the-scope clips, and we were able to close over the hole. And she ended up leaving 2 days later, which if we had done a laparotomy, there's no way she would have left in 2 days. And, this happened to come in when I was covering acute care surgery. So this kind of worked out well that we were able to manage it that way. So, the endoscopic approach can be really nice for patients. It can kind of shorten their recovery and provide a way to intervene for these difficult clinical problems without having to do a big operation. I think our ACS service probably would have done a big giant laparotomy and left her abdomen open, and she would have been in the hospital for weeks. And instead we were able to do an endoscopic management. So, so I think having these tools in your toolbox is really important. And that's what BESAFE is all about. This really what the efforts of the Flexible Endoscopy Committee with ASMBS, we're really trying to promote that our surgeons need to have this as a part of their skill set. It's not just about what we can do operatively, but also what we can do endoscopically. So there are actually a lot of different toys out there to treat a leak. You see a few of them pictured here. So this is what we call a pigtail stent. And so this is very nice if you're trying to do internal drainage of a leak. So patient has extravasation of contrast like you saw there, but it looks like they might have an abscess or something. Again, surgical repair is an option, but then we have these different endoscopic ones. So drainage internally, if there's pus, if we could drain it into the lumen, you can deliver one of these into the outside of the lumen of the stomach, and the inside part sits within the gastric lumen. The key is that opening has to be small, kind of like that picture that I showed you here. If we did have an abscess there, if this had been festering for a few days, we could have fed one of those through there to kind of internally drain that abscess so that we didn't have to place a drain externally. Because if we just close this hole, for example, with a clip, and there's an abscess outside, eventually we're going to have to figure out a way to drain that fluid well, and either that's surgically or this internal drainage. If you have a big opening and a big collection outside the stomach, this is where the endovac comes into play. And that's this little device here. And it's basically like an OG tube or an NG tube with foam sewed to the end of it. And this is done, you can kind of build this on your own. And you place it just like you would a wound vac, but it's placed transorally. The problem with this, it's pretty labor intensive. You have to do a lot of changes every couple of days, just like you would with a wound vac. And so this can be difficult to the system, but again, one more way to avoid an operation, particularly with a very big hole, and can really help a patient get through an extremely difficult situation. And then other things that we have clips. So these are the clip that I showed you before was called an over the scope clip, and that's kind of more of a bear claw. These are the kind of this more standard clips that really just catch the mucosa. So these are not extremely effective at closing fistulas, but good for the use of bleeding. And then this is the kind of over the scope clip that's more of a bear claw that takes like a giant bite all the way around the opening there. Strictures are another thing that can be really, really challenging for us to manage, right? And most of the strictures that I see after a gastric bypass has to do with patients' medications, ulceration from smoking, and then I've seen a couple from infections. One thing that a tool that's really good to have in your toolbox is knowing how to dilate. And so we have all these nice little dilating balloons that we can place through our cameras, and you can see this patient's opening is literally like 2 millimeters. Turns out this woman was on methotrexate for a long while without any PPIs. And once we were able to stop her methotrexate, get her on PPI, work on dilations, we were able to get this to stay open. So you can see we were able to place a balloon through there. We're able to stretch it. There's a lot of inflammation, right? It's very red, it's very thick. So you want to, one of the keys is you don't want to over dilate. One of the ways to know to not over dilate is to know how the anastomosis was done. So if you have a circular stapler anastomosis, like a 21 or a 25, for a 21 stapler, you don't want to dilate over a 15 millimeter balloon. For a 25 EEA, you don't want to dilate over a 18 millimeter balloon. I say that because I still use a circular stapler, but then you have most people, I would say, do a linear stapler nowadays for this, and that you can dilate kind of ad nauseum, right? I mean, that one you can stretch all the way up to 20 millimeters. But if you try to stretch it bigger than how the anastomosis was made to begin with, you might cause a perforation. So important to know about that. The other thing is that when you're placing the balloon for the stricture, in that example that I showed you, you can't see past the stricture, right? So if I were just to pass my balloon, pass it blindly, there's a potential that I could perforate on the other side. So this is where we want to use fluoro to kind of help us with that. So we could use fluoroscopy and kind of see our balloon staying in the lumen by placing some dye, pass the balloon into the lumen, and then stretch it out. Ideally, what I try to do is get past the stricture and pull the balloon into place if I can. And then one of the notes I have here is the watermelon seed effect. And I don't know how many of you in the summertime eat watermelons, and you take this watermelon seeds and you pinch them between your fingers and you can shoot them and have seed spitting contests. But if you place the waist of the balloon or the part of the balloon that's too close to one end or the other, it's going to squeeze out of this stricture. Whereas if you're using the waist of the balloon, it's going to work just fine, and it's not going to squeeze out. So, you want to start with whatever small balloon that you think will fit through it, and then slowly progress your way up, and be careful not to over dilate. Judy already followed up on some of these key findings after a sleeve and retroflections. So I'm just going to skip right past there. VBG, she talked about. And I think that's what I had to share about endoscopic complications. Questions, because I covered a lot of stuff and I could probably talk about each of these things for hours, but at least wanted to provide a good overview to everybody.
I think this is a fantastic discussion. Thank you, Dr. Khaitan, for that overview. I think to your point, that's endoscopic management and of complications is like a 4-day, 8-hour course just to start. So covering it as quickly as you did is just amazing. I did have a few questions, and for the fellows that are on, if you have any questions, please feel free to add them to the Q&A. I'd be curious, you mentioned when you were talking about stents for leaks and esophageal stents specifically, that the fully covered are more likely to migrate and then the partially covered. How do you secure it in place? Do you use clips or sew it in place?
Yeah, so there are a lot of tools to do all of those things. I mean, most of the time when I'm placing these, I'm trying to, I usually will use like a Merit 20 or 22 millimeter diameter stent, and I'll place it. And hopefully it will, I like it to stay in place, but if I'm worried about migration, we've used clips. I think that clipping is the easiest to do. Suturing is definitely there, but you got to have a big enough lumen to also kind of play with that suturing device, and putting those sutures in the esophagus is a little bit of a challenge. So oftentimes what I have done in these cases is I will go back in laparoscopically and place a drain externally. I have done that just because I think that if I do that drain and it's not horrible in there, it's be better than IR risking a pleural effusion and getting into the chest. So when I place that drain externally, then at the same time, I'll place some laparoscopic sutures to sew the stent into place. And I'm placing it endoscopically at the same time. And then I make sure that that's an air knot. Oh, hold on just 1 second.
You're on mute.
Yeah, I just realized that. We do have a question in the chat while Dr. Khaitan's on the phone. I'd love to hear what you thought. How do you address persistent non-bleeding GJ ulcers endoscopically, or do you address them endoscopically at all besides monitoring them?
So I think it, of course, really depends on the clinical, factors involved. As Dr. Khaitan mentioned, persistent nicotine use, medications, other aspects. But there are information about oversewing ulcers, as well as other endoscopic. I can let her talk, but when I did a research presentation on ulcers, I think that really, really understanding how PPIs work. So it is so important that you have an acidic environment. And so as patients take their PPIs and the Caravate together, which you shouldn't. You have to do it separate. You can't do it with other meds or other food. Also, like opening the capsules, there's data showing that that is way more efficient in helping the resolution of the ulcer. So I think that's part of our problem. We don't really instruct, or patients may not truly understand how these medications have to have ideal environments to work. And so that can be a part of making sure you're giving the right information for patients.
Absolutely. That's so important, Judy. My nurses are like uber trained on making sure that the patients open the capsules, and the patients will be like, well, I like my Protonics, the tablet. I'm like, well, that's great, but it's just not going to work that great. I mean, you can use it, but if you still have an ulcer on the Protonics, then we're going to switch.
Yeah.
The biggest problem is those patients who need to be on Plavix, because you can't give them the omeprazole and the Plavix. So for those patients, I'll use like the Prevacid granules, then that seems to not have the same interaction. Be a good opportunity.
That's a fantastic pearl. One last question that I wanted to ask. You guys hit on so much. I was curious if either of you had gone back to the OR on a patient who has a Novesco clip in place. It's something I've thought about a lot. If you have, how have you navigated it? What do you do? Did you get it out of the way?
So are you talking about
Say you perforated ulcer or maybe a persistent leak, because we used to use Ovesco clips a little bit as an adjunct once a hole got smaller for a leak, for some of the leaks, but they didn't always work. And so we had one or two that turned into chronic leaks where we ended up taking them to the OR. Maybe we should have waited longer. We had waited like about 9 months at that point. So just probably not going to heal.
9 months is a good trial
Yeah.
there, Shaina. But
Fair.
so if that leak is still there, in my experience, I've only gone back once or twice, but if that hole's open, it's just a foreign body that's kind of floating around freely, so you can remove it pretty easily.
Awesome.
So if it's in the way of allowing you to properly close the hole because the foreign body is actually holding it open, because it didn't adequately close it, there is a remover,
Okay.
So that's what I would do. Yeah.
Awesome. Well, thank you guys so very much for your participation this morning. We are 2 minutes over, so definitely have to give everybody back their mornings. if you have questions that we didn't get to, feel free to message me, and I can send out we can send out their answers either at the beginning of the next fellow project, or feel free to answer them this afternoon when they come back to talk to our West Coast fellows. Thank you. Special shout out to Dr. Chen. She's on the West Coast, so currently it is 5 a.m. her time. We really appreciate her participation. Dr. Khaitan, thank you for braving a blizzard for us. We are truly appreciative. Y'all have a wonderful day. Thank you so much.
Thanks, everybody. Great to see you.
Yeah, and just one last thing, if you do the BESAFE, it's at the beginning of the conference, so you have to build in time earlier to come in if you do sign up first. So just FYI. And there's also usually an endoscopy course, which really is fantastic, led by Dr. Khaitan. So consider those parts of your travel when you're considering coming to this conference and building that part in.
We'd love to see
Thank
you there.
you.
Yeah, have a safe and wonderful day, everybody.
Take care. Bye, guys.
Hey, hi everyone. Hey, Marc, how are you?
Hello, everyone.
So it looks like it's going to be us with the fellows today. I don't think our speakers could make it.
Sounds like an exciting opportunity for the fellows to ask us all sorts of questions.
Yeah, we're happy to answer what we can. Thank you to the speakers. I know they're not here, but we do appreciate their involvement and their talks this morning.
I'll just offer something that maybe starts the conversation. I recently have had both a stricture and a leak after a bypass. It's been a very unfortunate year for me, and I've been very sad that I can't do these things myself, that I had to rely on GI. So I would offer to the fellows out there that learning how to do endoscopies and manage your own complications, it's so important to being a successful bariatric surgeon. It's very difficult to be looking into the eyes of your patient and say that they have a stricture, but I can't tell you when GI is going to fix this for you, and I'm waiting like you are. That's a very difficult conversation.
Yeah, I'd have to agree with you. It's always nice to have partners in GI that can do these things, but it's also nice to be able to take it into your own hands when necessary.
Do you do your own endoscopies, Kamran?
I do. So I do my own pre-ops and post-ops. I have moved away from suturing fistulas. A lot of times it's because there'll be patients that come to us from elsewhere, and they'll just be directed straight to GI. And when those fail, they'll end up coming to us as a surgical eval. But in my own patients, it's mixed. Sometimes I feel like the advanced endoscopists are better equipped than I am, especially for stenting and securing those stents from migration, etc. So I'll usually shy away from doing that. I have done it in the past though, when it wasn't available. But we have two really great advanced endoscopists here, and so I rely on them.
And if I could ask you a question, since you do endoscopies routinely, what do you think about these new recommendations for follow-up endoscopies on sleeve patients? I haven't started to do that yet, but I'm scratching my head and wondering if I should be. I've been doing sleeves since 2007, and it would be awkward for me to reach out to them and say it's time for you to come back for your follow-up endoscopy.
Yeah, I mean the guidelines are interesting because I think most bariatric surgeons are not in compliance with the guidelines, including myself. It's an issue of, well, it's state and insurance specific, but not having a clear indication for surveillance endoscopy is a problem for a lot of our HMO and publicly insured patients. The other problem is we lose a significant portion of our patients just to follow up, let alone scheduling an endoscopy. So I think from a pragmatic standpoint, it's problematic. I don't know what to tell you. I don't do it either. I don't know if I should say that because this is being recorded.
I didn't hear anything.
I'll do it. I'll do it on a select group of people. I think it's I do it on an individual basis, but I don't do routine screening post. I don't know many people that do.
I actually have a former resident, since nobody's asking questions yet. I have a former resident who told me that he has started to do routine endoscopies on his bypass patients, and has found a surprising number of asymptomatic strictures. He said that he's, preparing to publish this, but just the idea that symptoms aren't necessarily correlating with findings, and he feels like he's getting after things before they become symptomatic. So he started doing it. He's in a setting where he has a more forgiving insurance population, but he's doing it at like 6 months after his bypasses.
Yeah, that's interesting. I wonder if intervention size of a stenosis correlates. I mean, presumably it does with the end outcome after intervention, right? So if you catch something that's stenosing or ulcerating and therefore stenosing, or ischemic and stenosing, and you intervene early, maybe earlier intervention confers an advantage. I don't think I've ever seen literature on that.
No, he's excited about, trying to put something new out there.
Yeah, that'd be pretty cool.
I'll also share with the group, since there are some young people here who are going to be looking for jobs in a short period of time. Very nice to be able to go apply for a new position someplace and offer endoscopy as part of the toolkit you're going to offer to the surgical group you're joining. Many surgical groups, they don't have that as an option, and that's an instant source of new patients. If you're a bariatric surgeon joining a program that may see 200 or 300 patients or more getting surgery done each year, and you can offer to do all those preoperative endoscopies yourself, that's an instant source of revenue for the new group you're joining.
Yeah, and I think that's a great point, Mark. And the other thing I would emphasize is the more endoscopies you do, the better you are at endoscopy, and the more comfortable you'll feel doing other things in endoscopy, right? So a lot of what I now do in endoscopy, I never did as a resident or fellow, and I learned from colleagues and partners over the past 10 years. But it kind of built upon just doing endoscopies. And so I don't do routine pre-ops anymore, but for a long time I did routine pre-op endoscopies, and I just got comfortable with that. So I would encourage the residents, just continue to keep your endoscopy skills up, and if you feel comfortable with it, that skill set will grow like anything else that you know how to do.
Yeah, I do feel like in a way we surgeons gave up endoscopies to the GI doctors. We historically did the first endoscopies, the first biopsies, the first peg tubes, the first biopsies of ulcers. We did all these things, and we handed it over to the GI doctors. Cameron, are you familiar at all with the BESAFE program? I'm actually interested in trying to take it myself this year. I don't know if I've aged out of the program.
I am familiar with it. I haven't done it, but familiar with it. The actually one of my new partners was actually talking to me about it. Um, I don't know if I have the capacity to pass the test anymore at this point in my life, but it does sound like so BESAFE and FSL, or I think it's the energy one. I don't know, maybe it's not FSL. What is it? FSE?
I'm not sure.
I got those came after my time, so I never went through them. But yeah, I'm curious to know what your experience would be.
Yeah, I think I might. It looks like there are 18 participants now. I'm gonna have to beat them to watching these 8 videos and taking the test, if there's a limited participation for the upcoming conference.
Oh yeah. The our posted the link. Well, I see a bunch of attendees just listening to us chat, but I guess there's no questions about endoscopy. Maybe if you guys have any questions about anything in bariatric or any of the previous sessions that Marc and I could chime in on.
Also, if you ask a question, it's recorded forever, so you'll live on in history.
All right, I guess should we call it?
I guess we could give everybody back 5 minutes to their Friday.
Well, I think our next session is January 3rd. Yeah, let me confirm that since it's right after the New Year holiday. I hope for those of you that can make it, Marc and I will be there. We do plan on hosting this Friday, January 3rd, and happy holiday season to everyone, including you, Marc.
Yes, happy holidays to everybody. We appreciate your attendance and be safe.
Be safe. Take care.